those are the studies that we have from 2016 up to a few months before this presentation. We'll go quickly through these studies. All the available SGLT2 types were intensively studied in these publications. The first one, as I've just mentioned, was published in 2016, conducted in Malaysia, and that was the main aim, which is the hypoglycemia and adverse events in dapagliflozin versus the sulfonylurea. We've just mentioned the main methods outlines of the study. And the main focus of the results was the hypoglycemia incidences. So the summation of any reported symptomatic or documented hypoglycemia in the gray bar represents the dapagliflozin plus metformin, and the red bar represents the sulfonylurea plus metformin. And as we see that during the last week of Ramadan, there was at least 4-fold higher risk of hypoglycemia in the sulfonylurea group compared to dapagliflozin group. And that took exactly the same pattern even 1.5 months after Ramadan. And this more or less is going along with the phase 3 and phase 4 clinical trials in SGLT2 platform. So the dapagliflozin showed at least 4-fold less hypoglycemia during and after Ramadan in this in terms of both documented and symptomatic hypoglycemia. More intense reporting that the documented hypoglycemia, again during the last week of Ramadan, was at least 4-fold higher in the sulfonylurea group, and almost 10-fold higher in the sulfonylurea group after Ramadan, 6 weeks after Ramadan. And this needs probably rethinking of why do 10-fold higher hypoglycemia in sulfonylurea group, and this probably not well reproduced in other studies. So the take-home message of this first ever SGLT2 inhibitor in Ramadan study, where the dapagliflozin was associated with lower risk of hypoglycemia compared to SUs. Dapagliflozin was, in general terms, was well tolerated. Other secondary outcomes included the postural hypotension and UTIs. There was a higher numerical incidence of postural hypotension and UTI in dapagliflozin group compared to sulfonylurea, but both were not statistically significant. So there was a numerical higher risk of postural hypotension and UTI in SGLT2 inhibitor group. The second study was a multi-center, multinational study. It's called Kratos trial, headed by Professor Hassanein, where the canagliflozin tolerability was assessed in this study. Again, the main endpoint was having one or more symptomatic hypoglycemia, and the secondary endpoint included hypovolemia, number of days where the fasting was broken, and other incidences of adverse events. A larger population of patients, 379 patients, again, equally distributed between SGLT2, sulfonylurea groups. Exactly the same pattern of the previous study. 4-fold higher risk of hypoglycemia, incidence of one or more hypoglycemia in sulfonylurea group compared to SGLT2, and reproduced and identically reproduced hypoglycemia rate. And here the hypovolemia events again concourse what we've got in the first study, that there was a statistically significant higher rates of hypovolemia, but that was not replicated in any change in EGFR in both canagliflozin or sulfonylurea group. The take-home points of this study was, again, canagliflozin was associated with lower risk of hypoglycemia versus sulfonylurea. Canagliflozin was well tolerated during Ramadan, and canagliflozin showed significant difference in hypovolemia frequency compared to sulfonylurea. A year later, we went more holistically, and we did a randomized, a real-world evidence study where we looked into safety of SGLT2 in different patients with different risk stratification, from mild, from low risk to high risk population. And we aimed to assess the frequency and severity of hypoglycemia, as well as frequency of hypovolemia and dehydration. Here, we aim to also to assess the difference in weight, HbA1c, creatinine between the two groups. And here in particular, we looked into the DKA incidences and the thrombotic events. The difference here in this study that we went into more senior citizens. We went up to 75 years of age. HbA1c average was 8.3 plus or minus 1.7. And with the acquired prolonged diabetes duration, 13 years plus or minus 6 years, half of the patients were on insulin and another half were on sulfonylurea. The total number of patients included 417. All of them were on SGLT2s. Half of them were on insulin. The results showed the total symptomatic hypoglycemia, number of patients who had at least one hypoglycemic event were 113. Only 93 of those patients did check the blood glucose when they had these symptoms, and only 78 patients out of this 113 had a confirmed hypoglycemia. So in another representation, 27% of patients had symptomatic hypoglycemia, 18% of total population had confirmed hypoglycemia. Interestingly, and this is we have seen it in so many different trials at different parts of the world, that only 1 in 3 of those patients who had hypoglycemia did break their fast. So, and this is the role of us, the healthcare providers, to enlighten and empower patients about the risk of hypoglycemia in Ramadan as the days go. Okay, so comparing the hypoglycemia incidences in patients with SGLT2 and oral hypoglycemic agents versus the SGLT2s and insulin. And as we've just mentioned, that 50% of patients were on insulin. So the total percentage of cases that had at least one incidence of hypoglycemia were 18%, and the confirmed were 11% out of patients with SGLT2 and oral hypoglycemic agents. Expectedly and interestingly, patients on SGLT2s and insulin had at least an incidence of 37% of symptomatic hypoglycemia, and 27% of them had a confirmed hypoglycemia, at least 2 to 3 folds higher risk of hypoglycemia when we move from SGLT2 at the background of oral hypoglycemic agents to SGLT2 plus insulin, whether it's basal insulin or more intensified course. And here it comes the difference between the basal insulin, SGLT2 on top of basal insulin, or MDI. Here, again, the percentage of patients on basal was 21%, compared to 31% on patients with more intensive basal bolus regimen, and that was again statistically significant. We did not report any incidence of DKA or thrombotic events, and the creatinine remained within the same level at recruitment and after Ramadan. So the take-home points here in this study was SGLT2 use with insulin significantly increased the risk of hypoglycemia compared to oral hypoglycemic agents. SGLT2s with MDI significantly increased the risk of hypoglycemia compared to basal insulin, and there were no DKAs, and EGFR remained, and the creatinine remained the same. In the same year, another study came from Singapore, where they wanted to assess the risk of ketonemia using SGLT2 in patients fasting Ramadan and they are on SGLT2 inhibitors. Here again, they went to a larger or the higher age group category from 21 to 75 years of age, And the most interestingly in this, most interesting methodology in this study is that they check the fasting plasma beta hydroxybutyrate level at 8 to 10 hours after fasting, and it was the second half of Ramadan, where at least the body will get used to the fasting and the use of oral hypoglycemic agents, whatever it was. And they wanted to evaluate the level of ketonemia in SGLT2 inhibitor patients compared to patients on other oral hypoglycemic agents. The ketone levels more than 0.6 was considered significant ketonemia. Small number of study population, 33 in SGLT group, and 29 patients completed out of 33 in the other control group of oral hypoglycemic agents. In a summary, there was no change in SGLT2 and non-SGLT2 groups in terms of systolic blood pressure, in terms of eGFR, and in terms of hyperkalemia before and after Ramadan. Interestingly, again, there was no difference, neither numerical or statistical difference in beta hydroxybutyrate in SGLT2 patients compared to non-SGLT2 group. Only one patient out of the SGLT2 group had a significantly high ketone levels, but it was asymptomatic, and the patient continued fasting the rest of the month uneventfully. So the take-home message of this study was continued use of SGLT inhibitors during Ramadan did not increase the risk of ketonemia, and as we all know that SGLT2s might be complicated by euglycemic DKA, but that was not the case in this particular study during Ramadan, and there was no eGFR deterioration or hypoglycemia in SGLT2 compared to sulfonylurea or other oral hypoglycemic agents. 2 years ago, we did this study was highlighted by Professor Hassanin a while ago, that we wanted to use the technology in assessment of safety of SGLT2 inhibitors in Ramadan, high-risk population, and the importance here that we have done it in 3 phases. We have seen the patient before Ramadan, the last 10 days of Ramadan, and 2 to 4 weeks after Ramadan. Again, more or less the same HbA1c, systolic blood pressure, diastolic blood pressure, and creatinine before and after Ramadan in SGLT2 and non-SGLT2 groups, except the HbA1c in SGLT2 groups was slightly better before and after Ramadan in terms of HbA1c. eGFR remained the same in both groups, so this concurs again that there is no renal jeopardy is expected using these medications during Ramadan. More in depth, the flash glucose monitoring data analysis, there was a difference in HbA1c that goes with the laboratory assessment of HbA1c. This is the estimated HbA1c from the flash glucose monitoring. There was no statistical difference in number of hypoglycemic events or duration of hypoglycemic events or the severity of hypoglycemia in SGLT2 groups compared to other oral hypoglycemic agents. And we concluded that this is the first study to assess the use of SGLT2 inhibitors plus insulin plus fasting glucose, flash glucose monitoring system during Ramadan. There was minimal interruption of fasting, and that was one of the secondary endpoint. Interruption of fasting, the number of days where the fasting was broken was less using the flash glucose monitoring, and this probably may aid or help in having a safer fasting during the month of Ramadan. The last and but not least, a very recent study published a couple of months ago, presented in Bangladesh Endocrine Conference, where they assessed the safety of empagliflozin using more or less the similar primary and secondary outcomes. And once more, there was no significant change in either biometric and biochemical indices, nor in eGFR. However, this inclusion eGFR was on the lower side, 79 average, and remained the same in SGLT2, 82, and remained almost the same in non-SGLT2 groups. So far, we studied low-risk patients with type 2 diabetes. We have a couple of studies in that category of patients. Higher risk patients, and our cohort included CKD stage 3, stable ischemic heart disease, and patients on multiple daily injections, senior citizens up to age of 75 years, and we have used the technology in our assessment. So with that, dear colleagues and friends, Mr. Chairman, I'd like to conclude my talk that the use of SGLT2 inhibitors seem to be associated with lower risk of hypoglycemia than sulfonylurea, and it was very well tolerated across different studies. Slightly higher risk of hypovolemia and genital infections with query clinical significance. Both randomized and real-world evidence SGLT2 inhibitor studies have shown a high margin of safety during the Ramadan fasting. However, risk stratification, dehydration, empowerment of patients is highly recommended. No dose adjustment is needed for in terms of SGLT2 during Ramadan, and that was reproduced in multiple guidelines and consensus statements. Benefits significantly outweighs the trivial adverse events of SGLT2s, so it might need to be on board during Ramadan. And with that, I'd like to thank you very much and hand over back to Dr. Khalid.